Okay.
Thank you. All right, let me lower this here. I'm tall enough to justify that. All right, you guys hear me?
Yes.
All right, thank you. My name is Jordan Benjamin. I am the director of the Asclepius Snakebite Foundation and here to talk about our model for snakebite treatment at the point of injury. So first of all, what is ASF? We are a certified 501c3 nonprofit. We're an independent group of clinicians and scientists who joined together in early 2018 to try and make a greater impact on the snakebite problem. So you probably know a lot of our team, Nick Brandoff from UCSF, Ben Abo, Medical Director of Envenomations, Jean-Philippe, Leslie Boyer, Eugene Arulu, Ray Morgan, Zelu Balde, Kate Jackson, and others. And we try to take an interdisciplinary approach, combining all of our various backgrounds to look at this from various angles and try and find solutions. Disclosure, so we partnered with Inosan to provide donated antivenom to patients in Africa free of charge. But I also would like to stress that all of our work is unpaid and all of our research is impartial. So there's a lot of things that we're interested in bringing out to the field, and we come from backgrounds in wilderness medicine, emergency medicine, and austere medicine. And I'm not going to get into all of these because I only have a few minutes, but I will just touch briefly on some of these. So we are trialing things like portable EKGs that run on smartphones, end-tidal capnography, which we'll talk about for this, point-of-care ultrasound, which is very versatile. Now it can work off of a smartphone, advanced airway management, various medications. And we've put together sort of advanced jump kits designed around airway breathing, circulation, antivenom administration, and prolonged field care for the first 24 hours after a bite. So today we'll focus on some of the challenges that we're addressing through the lens of our clinic in Guinea. We recently set up a partnership with the only snakebite clinic in Guinea. They're a very interesting location. They get over 600 bites a year by a lot of very dangerous snakes. So black mambas, green mambas, forest cobras, puff adders, rhinoceros vipers are among the main culprits. And they're already achieving very impressive results despite a lack of resources. They have 5 beds, they have 1 pillow, they have no ventilatory support or resuscitation capabilities. They didn't until a month ago. But this talk is in many ways about how we can try and improve these cases further by bringing simple supportive care techniques from other areas of medicine into the field. And just to sort of demonstrate the volume of cases they get, this is one of the clinic records here. This is 5 bites in a day, 2 pediatric cases, 4 Envenomations, and 1 fatality. And this is almost exactly a year ago. So they get quite a number of cases. So this is further complicated by the fact that around 30% of cases at this clinic are neurotoxic bites, and they don't have airway management. I'm going to show a brief video here of sort of what typically happened at the clinic. So this is a patient probably with a mamba bite based off of the sort of hypersecretion syndrome. Patients would be, by necessity, they'd be given antivenom and then brought out to the porch for fresh air and fanned and positioned to try and prevent aspiration of vomit, but that's about all that could be done. So there's a lot of opportunities for supportive care, for innovative adjunct therapies like what Matt Luden's working on, to come in and sort of increase the survival. And in a lot of these patients, they'll survive with antivenom, but sometimes you need something to get them to the point where the antivenom kicks in. So this patient, as you saw at the end, received a few vials of antivenom and made a full recovery. It's not always the case. This is another patient they had there when Ray Morgan and Leslie and Jean-Philippe were out there, who died shortly after arrival because of respiratory arrest. So this is a patient who could be saved with supportive care. There's a lot of challenges associated with airway management in an austere environment. Anyone who's bagged a patient before knows that it's hard work and it gets harder over time. And it's easy to increase errors as you go. It's hard to maintain a good rate and a good tidal volume over minutes even with a patient, let alone hours or potentially days. It's hard to maintain a good seal. It's easy for patients to aspirate, and you can place advanced airways, but there's risks associated with that. And then even when those are placed, there's risk of displacement or obstruction of the tube, as well as many other issues. So these interventions come with significant risk, and bag mask ventilation, which is really our bare minimum of what we need in a lot of places, requires the total attention of at least one person to do it right, and two if you don't have an advanced airway placed, because it's almost impossible to make a good seal. So one of the sort of novel things we're trying to bring out to the field is portable end-tidal capnography, and using this early on to guide decisions in airway management, and also to reduce errors, especially by inexperienced users. So capnography is basically a measurement of your exhaled CO2, and it provides a visual representation of waveform and a number. And the waveform is in real time, and it also, to the right there, gives you a respiratory rate. It's very, very sensitive. It detects signs of changes in airway patency up to 4 minutes earlier than pulse oximetry, which is a lifetime for a patient who's not breathing or not breathing well. So take a look at this video here. Pay attention to the rate, the numbers, and the waveform, and how they change almost immediately as I change my breathing rate here. One of the nice things about capnography is you don't get a good waveform for more than 5 or 10 seconds unless you have a good tube in place, or unless you have a patent airway in general. So as long as you have a good airway, you can confirm it with a number, you can confirm it with a waveform, and you get a very sort of a real-time responsiveness that tells you whether something has shifted or whether you need to move to a more advanced intervention if you're not getting the response that you need there. It works in patients who are intubated, works in patients who are not. This is designed to be, this particular device is about $600. It's been in use by special operations for over 6 years. It's very durable, it's easy to disinfect, no moving parts. We thought it would be a pretty good option for our setting. It's designed to be a mainstream device, but with a bit of duct tape and a non-rebreather, you can get a functional side stream that's accurate enough to trend your vitals. And it's useful even, again, attached to a bag valve mask or stuck onto a non-rebreather placed on the patient just to trend, are things moving in the right direction or not. So we were out there in July and August, and we focused on sort of an assessment-driven approach to try and fill some gaps in airway management, with the principle that the decision to place an airway adjunct should be guided by good physical assessment skills and early use of tools like portable end-tidal capno. And that the simplest option is probably the best. So we taught them to do positioning, placing a pillow under the shoulders to align the ear and sternal notch, which opens the airway, aggressively prevent aspiration. Jim DeCanto gave us a bunch of suction catheters that he invented for airway decontamination, bag mask ventilation. We focus on team-based resuscitation, which is a new concept over there. They're not used to applying that in these cases. And we went up to supraglottic airway devices as well, which can be placed blind without laryngoscope, and also may afford a better protection of the airway than ventilating with a bag mask alone. So 2 days after we left, we did a sort of a month-long airway academy with them. 2 days after we returned home, a 10-year-old boy was rushed to the clinic in serious condition with a neurotoxic snakebite. So here is probably a forest cobra bite based on the lack of hypersecretion there. He presented in pretty serious condition, ptosis, respiratory muscle weakness, neck flexor weakness, dysphagia. He's unable to protect his airway. Very sick patient. So see if supportive care made a difference here. You can see they placed the pillow under the shoulder to elevate to open the airway anatomy. They decontaminated the upper airway with suction, which increased its oxygen saturation. They gave rapid push of field-stable antivenom and IV fluids to maintain the blood pressure. They rapidly rolled him, guarded his airway. These are all basic interventions, but they were guided with the use of capno, which helped to ensure that, to confirm for them that they were getting adequate ventilation. They didn't need to move to a more advanced, potentially riskier intervention. And several hours after receiving antivenom, pretty dramatic improvement. So in this case, the patient was stabilized, kept alive with supportive care. Great work by the team there. There's a lot of other areas we'd like to dive into. Another one that we're currently looking at is ketamine for analgesia. Current WHO guidelines recommend paracetamol, which is good, it's safe, but it's often ineffective, or opiates, which come with risks of respiratory depression, hypotension, things like this. In emergency medicine in the United States and in austere medicine, sub-dissociative dose ketamine has been used. It's been found to be very safe and effective for many years. And so Nick Brandehoff, one of our emergency physicians, is working on a project to bring that out into the field as well. And we've seen good early results. And this is particularly interesting, I think, because the association between untreated acute pain and PTSD are very real, as is the association between PTSD and snakebite. So if we can bring safer analgesics into the field, maybe we can reduce that incidence overall. So that's my presentation. Thank you, IST. I have this picture of the blind man and the elephant because I think that's sort of a good representation of the snakebite crisis. We all see this differently through the lens of our own backgrounds and experience. The reason we started this foundation was to try and bring together everyone with a different perspective to bring their own unique experience to solve this problem. So we're always open to collaborating. I actually brought the capnography here. If anyone is interested in seeing if they think it would be effective, feel free to come play with it and see what you think. Thanks to our amazing team, and thanks for having me.
Are there any questions?
Question.
Yes.
Thank you for the presentation. This issue of the antivenom efficacy for neurotoxic envenomations, as you know, is kind of complicated because these neurotoxins are very poorly immunogenic. Do you think it would be feasible to increase, because you mentioned 2 vials in a treatment, it seems to be like a low dose. Do you think moving up the initial dose of antivenom would improve this? Are you considering using more antivenom to revert these neurotoxin symptoms?
Yeah, it's a great question, and I absolutely agree with you. I think 2 vials is way too low. One of the things we're hoping to do at this treatment center is to start a large double-blind randomized controlled dose ranging trial for antivenom, specifically for neurotoxic bites, because they have such a high incidence. And I agree, there's so much we don't know about who will respond and who won't. I could do many other presentations, and I'm sure there are people in the audience who would have much better answers than me, so I won't dive into that except to say we're very interested in it, and the hope with this project is that we can try and keep people alive long enough for antivenoms to work now. But ultimately, we need new solutions.
Thank you.
Thank you.